learn. It, it's been a great opportunity for us to learn as an organization in the industry, but also then to impact the knowledge that we are hearing from experts and bringing experts to really share their knowledge with the rest of with the community. It's been Today we have a very exciting series. A very exciting conversation today with John David Clip. John David is the publisher of Laboratory Economics, one of the really most prominent journals in the for business leaders in the lab space. I do get the publications and fascinating content that they publish, and today we're going to be talking about the trends shaping the future of diagnostics. There's been a lot of changes, a lot of really news, about laboratories, and we do want to dive into some of those things. What we're hearing, the conversations we've had with other folks in the industry, and how we think these things could shape our market. It's just in the last year alone, there's been so many things going on in the lab. So we're going to dive into those today. The three buckets we're really going to cover. We're going to cover the macro. What are we seeing? What is the pulse of laboratories? The second bucket we'll cover will be around some of the legislative and regulatory changes we've observed in the market in the last year, and how we think those things are going to change the trajectory of the industry in 2025 and into 2026. The last bit that we'll cover is on technology. There's again been a lot of technology advancements, and we're going to really look at some of those observations and see which of them are beneficial for the laboratory and what hasn't been very beneficial for the laboratory. My hope is that you come out of this energized and excited about the future of the industry and where things are going. So without further ado, I want to introduce John David. So John David, can you please help us really understand today, based on this, this time and place, how are labs doing?
Today, right now as we speak, they're doing okay. The reimbursement for roughly the past 5 years has been flat, and volumes are growing somewhere on average. If you average out clinical lab testing and anatomic pathology, somewhere between 2 and 4% per year, and that varies widely depending on the testing segment. For example, I know that PCR test volumes are increasing at over 30% per year. Again, it depends on which particular sector you're looking at. And the main challenge is on the cost side. Post-pandemic inflation, both for supplies and especially for labor, medical technologists and pathologists and all other lab workers have been increasing higher than normal, and that's been a challenge to balance growing volumes together with growing supply and labor costs. So that's where we stand right now today, although things look like they could be changing in 2026.
That makes a lot of sense. It sounds like things are changing. Things could be changing in 2026, and so one of the things you mentioned was around some of the legislative changes we have observed. We've talked a lot about, we've heard a lot about reimbursements and where that could be headed. So from your perspective, what are the recent or upcoming changes to reimbursements that might be impacting lab decision making?
Sure. So in my mind, and I always view things from more of a business and financial perspective than a lot of people in a lot of laboratories and pathologists might. But in my mind, the biggest story or the biggest news or change right now today is after 5 straight years of a frozen Medicare clinical lab fee schedule rates. So for the past 5 years, at the end of each year, there's been a short-term 1 year freeze to the Medicare clinical laboratory fee schedule reimbursement rates. That's occurred late in the year. This last year, late in the year, another 1 year freeze kept clinical lab fee schedule reimbursement rates flat. And up until recently, it had become the view, my view, as well as the view of many other people in the lab industry, that these 1 year Medicare clinical lab fee schedule reimbursement rate freezes would continue indefinitely. And that changed a few weeks ago when it was discovered or found out that the Congressional Budget Office would be changing the way that it scores or estimates the cost of a 1 year freeze to the Medicare clinical lab fee schedule. So prior to a few months ago, the CBO, the Congressional Budget Office, had been under the assumption that private payer lab rates were increasing each year at the same rate of inflation, and therefore they believed or estimated that a 1 year freeze would save the government was going to each year was going to save the government money. And recently, they have let it be known that they no longer believe that private payer reimbursement rates for clinical lab tests are increasing at the same rate as inflation, which we pretty much all know is not occurring or hasn't occurred. And as a result, another 1 year freeze is probably off the table for 2026. So what that means is that the PAMA regulations will resume after a 5 year pause. The PAMA regulations will resume in 2026. And what that means is that a scheduled rate cut, Medicare rate cuts for, I think it's 792 clinical lab tests on the clinical lab fee schedule will be the reimbursement rate, the Medicare reimbursement rate will, for those nearly 800 tests, will be cut by up to 15% each. So that doesn't mean that all 800 lab tests will be cut by 15%, but they'll be cut by up to 15%. And we analyzed those 800 test codes and looked at the highest volume test codes. And what we figured out was that the average rate cut to the average laboratory, and it'll vary depending on your test mix, but the average rate cut would be approximately 8.5% in 2026. And again, we're just talking about the clinical lab fee schedule. And it'll vary depending on your test mix. But for the highest volume test, we looked at the 25 highest volume tests, and some tests are not going to be cut at all. And some tests might be, the reimbursement rate might be only cut by 5%, and others will be cut by the maximum 15% in 2026. But what we found was that on average, there'll be an 8.5% Medicare clinical lab fee schedule rate cut. And some examples of some higher volume test codes that will be reduced are PCR testing for not otherwise specified will get the full 15% rate reduction by Medicare. The comprehensive metabolic panel, which may be the highest volume test out there, will be cut by, reimbursement rate will be cut by 14%. TSH will be cut by 11.5%, and the lipid panel will be cut by the maximum 15%. So, and with the resumption of PAMA, the PAMA regulations, The other thing that will occur is that the private payer survey, private payer payment survey, which has been on hold for 5 years, will resume in 2026. And what that means is that labs will need to report their private payer volumes and payment rates going back. They'll need to get their data from 2016 and report it to CMS by March 31st, 2026. And these private payer rates, now it doesn't make much sense to go back to 2016 and collect that information to use to calculate new Medicare clinical lab fee schedule rates, but that's the way the law is written, and that's the schedule. Uh, uh, so your private payer rates from 2016 will need to be reported by CMS by March 31st, 2026. And CMS will use these private payer rates that all the labs have reported to calculate the new Medicare clinical lab fee schedule rates in 2027. Now, let me just add one more thing, and that is that the American Clinical Lab Association is working on a new legislative proposal that would delay a long-term fix. So they're working on a long-term fix to the PAMA regulations, and that would delay these scheduled cuts and the next private payer survey. And the goal is to delay the scheduled cuts and the next and make sure that the next private payer survey includes the correct amount of information from hospital labs, because hospital labs are paid much higher reimbursement rates from private payers than independent labs are. So ACLA wants to make sure that those higher hospital lab rates are included in the next survey, the next private payer survey, which, if they're successful, and it's going to be very difficult to get this new legislation, this new bill, when it's introduced, it hasn't been introduced yet, to pass into law. But if they are successful, that would delay the cuts that are scheduled for 2026, and it would also ensure that hospital labs and the higher payment rates that they receive from private payers are accurately included in the next survey. And what this would do would be to either stabilize or even possibly raise Medicare rates. If you can get hospitals and their high rates accurately included, there's a chance that it could actually either stabilize or actually increase Medicare clinical lab fee schedule rates in the future. But it's a long shot. It's going to be difficult to get that new legislation, that new bill that they're working on. It hasn't been introduced yet. It hasn't been unveiled yet. But there's a hope that there'll be that could be successfully passed into law, and it would be really a tremendous blessing for the lab industry if they're able and successful at getting that anticipated bill passed into law.
That's really interesting. I want to go back to that because I remember the industry was trying to introduce salsa, and then that went through Congress, but ultimately failed. And now ACLA is really trying to introduce this new bill. Now, we're gonna talk about this later on, during our conversation, but the Congress and the Senate are really, really busy, and they're very busy with a lot of things. But at this point, they're talking about this big, beautiful bill, right? So when we think about this new policy that the ACLA may be working on to help maybe prevent the PAMA cuts from coming into effect in 2026, is there really a realistic shot of getting this into the big beautiful bill? Is it too late? I mean, what are we talking about here? Because we only have
Yeah.
6 months to go in the year.
Yeah, that's a good question. So it's too late to get it introduced into the big beautiful bill. Because ACLA hasn't even introduced the proposal yet.
Mm.
So we don't. Uh, at sometime in the next few weeks, it's expected that ACLA will introduce, get sponsors for, and introduce the bill, but it's too late to
Okay.
get put into the current big beautiful bill. The hope is that it could get inserted into an end of year. It's anticipated that there'll be new legislation, new healthcare policy legislation introduced at the end of the year, and possibly some other big legislation introduced and passed later in the year. So it's too late to get put into the big beautiful bill, but the hope is that it could get inserted into a package, either healthcare policy or some sort of
Okay.
budget package later near the end of the year.
Okay, that's fair. And then on this as well, I mean, you mentioned, they are expected, labs are expected to produce 10 years worth of, private payer volume and payment rates. I mean, a lot of labs and even hospital systems have actually migrated from legacy systems to, in the last 10 years. I mean, how easy is this? Is it to really have access to this data or be able to get this data? I would think it's really challenging to do.
Yeah, it's challenging, especially from the hospitals. I don't think the hospitals don't have the systems in place. Many hospitals don't have systems in place going back. And now, not only do they have to have the reporting systems in place, but they have to be able to collect the information from 2016.
Yeah.
And over the past, that's been 9 years. And over the past 9 years, that's hard to believe, but it's 9 years. I'm sorry. The data will be collected from 2019. So yeah, it'll be 6 years
Yeah.
since 2019. So they'll need to report their private payer data from 2019.
Okay.
And even 6 years is a long time. Many hospitals have upgraded their information systems and their databases and may not have access to 2016 data. So anyway, long story short, it's going to be particularly challenging for hospital labs to report their private payer data from 2019. It is that they need to collect the data for. And that's why ACLA and the industry, it's so important to get PAMA rewritten or amended so that you don't rely on hospital labs reporting their 2019 data. And what ACLA, what I believe ACLA is going to propose is they just get a statistical fair representation of hospital lab rates uh, um, that will be used by CMS to calculate clinical lab fee schedule rates. Because again, during the first PAMA survey, hospital labs were underrepresented, and they want to make sure the goal is to make sure that they're not hospital labs and the higher reimbursement rates they get paid by private payers are not underrepresented again this time around because it's so difficult for them to collect and report that information.
Fine. All right, so we're gonna move on to the big beautiful bill then. There are lots of things in that in the bill. So one of the components of it, and been a lot of it's been in the news a lot, is the potential proposed Medicaid cuts. This is certainly something we've heard from some of our customers that this is is given them and not just our customers really, even when I talk to folks in pharma and biotech, it's given a lot of people cause for pause in some decision making. Let's just start from what are for a laboratory, what should they be thinking about, or like, can you help them better understand this, the Medicaid cuts and what that impact could be for them?
Yeah, sure. Um, so probably the biggest impact on laboratories from the one big beautiful bill, assuming it gets passed into law, would be enrollment cuts to the Medicaid program. So
Mm,
there are currently 71 million people in the United States covered by Medicaid, and the bill that went from Congress to the Senate proposed 793 billion in cuts to federal Medicaid spending, and the cuts would be achieved by implementing work requirements for Medicaid recipients, increasing the intervals at which the redetermination for Medicaid eligibility were set, and also by cutting federal funding for states that are providing Medicaid benefits to undocumented immigrants. So on the Medicaid side, it won't be reimbursement rate cuts. It would be lesser enrollment in Medicaid programs. So the Congressional Budget Office has estimated that if the One Big Beautiful Bill, as it stands, at least yesterday or the day before yesterday, has estimated that if it's passed into law as it stood a day or two ago, and the bill is going to go through a lot of changes and revisions. I think it's going through some changes and revisions in the Senate as we speak. But anyway, the Congressional Budget Office has estimated that it would reduce Medicaid enrollment by between 8 and 16 million people by 2034. So here's some things to put into perspective. At 71 million people covered by Medicaid currently, that represents roughly 20% of the U.S. population. I think the U.S. population today is somewhere around 345 million people. And so Medicaid accounts for almost 20% of the population is covered by Medicaid. And if the and then in terms of lab spending, my rough ballpark estimate is that Medicaid represents, and now I'm talking about both traditional fee-for-service Medicaid as well as all the people on Medicaid that are enrolled in managed care or private insurance managed type plans. But anyway, it's estimated that 10 to 20% of lab test spending comes from, or lab test revenues come from Medicaid fee-for-service as well as Medicaid managed care plans, just to put things into perspective. Now, I just would point out one more thing, and that is that because Medicaid reimbursement rates are based off of Medicare, the Medicare clinical lab fee schedule, if the Medicare clinical lab fee schedule rate cuts in 2026 go into effect, and ACLA the industry is not successful in getting past a long-term fix to the PAMA regulations, Medicare clinical lab fee schedule rates influence Medicaid lab test reimbursement rates. So you could potentially have lesser Medicaid enrollment, and then if the Medicare clinical lab fee schedule rates cuts go into effect, they would filter down to what each state pays for Medicaid labs for on their lab test fee schedules.
Okay. I mean, it's interesting because I know obviously this is in flux, right? A lot of it could still change a lot. It's possible that the Senate are going to make some adjustments to the bill today, and then send a different package to the House, to the Congress. So we don't know where things are going to end up aligning ultimately. But I would like to get a perspective on this. So we were talking about this earlier. Back during COVID, Medicaid enrollment was up to 19 million people were covered by
91 million.
Yeah, okay. 91 million people were covered by Medicaid. More recently, we have about 71. So really, that's an attrition of 20 million people, right? And and we're thinking that, well, it's possible that if the bill is passed into law the way it is, there'll be, call it 10, 15 million people who will lose Medicaid coverage. Can you sort of put things then in perspective for us? Because with that, with the reduction through since COVID, obviously it's not been good news for laboratories, but it hasn't been catastrophic for the lab industry. And so if we, if we were to go from 71 to 61, while that's not great for the lab industry, maybe it's not going to be catastrophic for the lab industry. Is that fair to say?
Absolutely. It absolutely would not be catastrophic. And as you mentioned, Medicaid enrollment during the pandemic increased to approximately 91 million Medicaid recipients in 2022 and 2023. And since then it's declined to 71 million. And it's just kind of gone under the radar. No one has really noticed it as far as I can tell. And so losing another, if the one big beautiful bill gets passed into law as it stands today, losing another 10 million Medicaid recipients certainly would not be catastrophic for labs. And the only reason I even bring it up is because it's the thing that would probably have the thing in the one big beautiful bill that would have the biggest impact, but certainly in no way catastrophic.
Makes sense. Okay. I think we've really talked a lot about the bad news in terms of clinical rates and the potential Medicaid costs. And again, that could impact different laboratories, differently, right? I mean, I think folks in rural areas that have more Medicaid enrollees in terms of their lab test zone will see the most impact. Some laboratories might not be as exposed to this in terms of risk. But we want to move to the good news, right? Because there are obviously some tailwinds, not just the headwinds. So can you please talk about this other component of the in the big beautiful bill that hasn't really been talked much about?
Yes, yes. So one of the very positive things that's included in the One Big Beautiful Bill Act, as it stands today, is the American Medical Association, as well as the College of American Pathologists and other specialty groups, physician groups, were successful in inserting a provision that would give inflation updates to the conversion factor that's used to determine all Medicare physician fee schedule rate reimbursement rates. So, we were previously talking about the clinical lab fee schedule. Now we're talking about the physician fee schedule, which has the greatest relevance to pathologists and pathology labs. And there's an inflation update written into the bill. And so just some background, in 2025, this year, the conversion factor, and again, this affects all physician payments, pathologists, professional fees, pathology lab technical fees, as well as all other physician specialties, whether a dermatologist or gastroenterologist or whatever, all physicians, as well as the technical services provided by pathology labs. But anyway, the conversion factor was cut by 2.8% this year, 2025, which was very unusual. Usually there's some last minute legislation that gets passed that averts or softens this type of reduction. But that didn't happen in late 2024, and the 2.8% conversion factor cut went into effect, which meant that Medicare reimbursement rates for pathology professional fees, as well as pathology lab technical fees, were cut by around an average of 2.8%, just like the conversion factor. It varied depending on the test code, but and again, that was very unusual. Usually there's a last minute legislation that softens this type of reduction. So once again, the positive thing is that if the One Big Beautiful Bill Act is passed into law and it includes the inflation update that's currently written into the bill, we'll pathologists and pathology labs will start seeing inflation updates to the conversion factor, which um, determines their payment rates under the Medicare physician fee schedule starting next year in 2026. So these inflation updates will be based on the Medicare Economic Index. It's similar to the Consumer Price Index that everyone's heard of, but the Medicare Economic Index is a measure of the inflation aspects of providing physician services to Medicare patients. So once again, if the bill as written today is passed into law, the first year increase would be would occur on January 1st, 2026, and physicians would get an inflation update equal to 75% of the Medicare Economic Index. So the Medicare Economic Index today is projected to increase by 2.3% in 2026. So if you take 75% of 2.3%, this would result in a 1.7% increase in the conversion factor. And again, this is applied to all Medicare pathology professional reimbursement rates as well as technical fees. The thing that's not so good about this inflation update is that while in 2026 it's set at 75% of the Medicare Economic Index, in 2027 and onwards, the conversion factor would only be raised by 10% of the inflation rate for medical practices. But the strategy is, and the strategy here is that the American Medical Association and CAP and all the other physician specialty organizations, they just wanted to get their foot in the door to get inflation updates. And again, it'll be 75% of inflation in 2026 and then 10% of inflation in 2027 and onwards. But the thinking is, if they could just get this inflation update written into law, then at some point in the future, they can raise these rates and maybe get 100% of the Medicare Economic Index, 100% inflation updates each year. So this was very positive in that it does give an inflation update that's estimated to be 1.7% in 2026. And then it gives the American Medical Association and CAP and other groups the opportunity to potentially raise these rates. 10% is a little bit ridiculous, but if they once again, if they figure if they have their foot in the door and it's written into law, it'll be a little bit easier to get that 10% raised to 50% or 100% in the future. Getting an inflation update is a big deal, and the challenge will be to raise the percentage of inflation that the Medicare physician fee schedule rates are increased by each year in the future.
Yeah, I mean, this is certainly good news for labs and really for the industry in the pathology, elite pathology labs. So any relief labs can get, especially at a time like this, with the tariffs potentially leading to increases in reagent costs and different sort of cost components, like talent and staff going up. I think anything that can really help the top line is great news. So thanks for sharing that. So I want to pivot. We don't have much time left today, but I want to pivot to technology. When I was reading the most recent publication in laboratory economics, I saw some really compelling stats, and we'd love to really sort of dive deeper into digital pathology adoption. It seems like there's a lot more. We've seen a lot more speed of adoption in the market, especially compared to more recent surveys that you've done over the last 5 to 10 years. So can you sort of walk us through what you're hearing, what you're seeing regarding digital pathology adoption?
Yes, and I'll try to be quick. I know I tend to talk too long, but so we did a survey. Laboratory Economics did a survey. We collected information from it was 120 different pathologists and lab executives, and so we know that just anecdotally, we know every month there's one or two major health systems that are moving to digital pathology, and we report on those every month. So we know that there's adoption is growing, and one of the questions we asked on the survey was for those labs that haven't already started digital pathology, what are the barriers to adoption? And it's really no surprise. It's because the process of digitizing a slide is not reimbursed. There's no separate reimbursement rate for that. So that's the biggest hurdle. Also related to that is it's too expensive. Again, related to that is there are large data and image storage concerns. That's another expense. And of course, it requires additional staff to load and unload and manage the digital pathology slide scanning effort. Now I don't have this, I don't have the graphics for this, but I can tell you that one of the questions in the survey that we asked was, so what is your estimated cost for those labs that are doing digital pathology? What is your estimated cost to digitize a slide? And the greatest percentage of respondents said that they believe their average cost to digitize a slide image is between $3 to $5 per slide image. And which sounds reasonable. My gut feeling is that the cost is a little bit higher than that if you add in the image management software cost and the storage of the digital images. But the answer we got was most frequently was that an average cost of $3 to $5 per slide for digitization. Real quickly, I'll say that again, the biggest barrier, if there was even just a few dollars reimbursement from Medicare and private payers for digitizing a slide, you would see the adoption rates probably go through the roof. But that may be at least a few years away. Medicare is in the process of analyzing the potential for separate reimbursement for digitizing slides. Again, I think it's going to at least a few years away before if and when they establish separate reimbursement for that technical cost. And in the meantime, the way that labs are getting a return on investment is through applying artificial intelligence to slide images, which can help pathologists identify hotspots on each slide imaging much more quickly and reduce their need to review non-worrisome slide images. And there are some labs that are very advanced in applying artificial intelligence. So obviously, if you can apply artificial intelligence, which helps your pathologist efficiency increase, then that would be your payback for the investment in digital pathology. And so again, it's something adoption is picking up, and it would be much quicker if there was separate reimbursement. On the other hand, many labs are viewing artificial intelligence tools as the means towards earning return back on their, investment in digital pathology scanners, equipment, and the staffing.
Thanks for sharing that. I mean, I was looking at the survey, and I know we don't have it here, but one of the really compelling stats to me was that about 50% of laboratories are already digitized, or guess applying some form of digital pathology in their workflow. Could you talk more to that? I mean, were you surprised? Because I was certainly surprised.
Yeah, and I want to just put a caveat there. So the 120 pathologists and laboratories that responded to our survey, I'm certain that was biased towards those labs that have already implemented digital pathology. And so there's no way that 50% of pathology labs are using digital pathology. I think that the truer number, I think our survey was biased by respondents who were more likely to be using it. And if I was forced to pick a number, I would say somewhere between 5 and 10% of pathology labs are have implemented or are using digital pathology. It's not 50%. And the one thing that the 50% number did illustrate was that if you look back when in previous years when we've done this survey, we've always got around 20, 25, 30%. And then this latest survey showed a huge jump up to 50%, which again, we believe is overstated. The true number is probably closer to 5 to 10%, but it does indicate the rate of adoption is increasing.
Yeah, yeah. I mean, we're certainly seeing that a lot of laboratories are really thinking about the future, which is great. So, I know we've talked about the legislative tailwinds, headwinds. We've talked about technology. At the end of the day, when you put all those things together, a laboratory now should be asking, well, if I have all these headwinds, how can I differentiate myself? How can I be better? How can I, just be able to run a sustainable business? So can you please talk about just quickly around the operational ROI that you're sort of seeing laboratories starting to sort of think, especially with some of the tailwinds, I mean, some of the headwinds that we've seen in the market?
Yeah, I might not be answering your question directly, but here's my answer anyway. I would say that despite the likely reimbursement pressure that's coming in 2026, uh, lab test volumes, whether it's clinical lab or anatomic pathology, consistently increase year over year in the 2 to 4% range, which is very positive. And the other fact or thing that I would mention is that uh, with respect to, let's say, hospital clinical lab outreach programs, independent labs uh, competing regionally, and then local pathology groups, whether hospital-based or independent. Um, I'm consistently, in the 30 years that I've been covering, writing about and following the lab industry, um, I've consistently been impressed by the ability, whether it's a well-run hospital lab-based lab or a well-run independent lab or a well-run independent anatomic pathology group. I've always been impressed at how they are able to compete based on turnaround time, based on service, based on having a live human being answer the phone when a client calls in with a question or a problem. Um, I'm every time I speak with once again well-run hospital-based labs, independent pathology groups, uh, their rates of growth are always substantially higher than what we think the market is growing at. So anyway, my point is that the market consistently grows, year in and year out, volumes grow 2 to 4% per year. And despite consolidation and the growth of some of the national labs, and it's more than just Quest and LabCorp. There's NeoGenomics and Path Group and other large uh, uh, pathology lab companies. Despite that competition, the well-run labs are consistently reporting higher than market average growth. Uh, and anyway, I want to end sort of. I want to introduce a very positive note, and there it is.
That's great. I appreciate that. So we are almost getting to the end of the fireside chat. We do have some time for Q&A. So please, if you have any questions that you would love for us to address, please put that under the Q&A. We only have 10 minutes or so left for the webinar. The one last piece that I want to talk about, and this is a shameless plug because I have to. But we have in the most recent months we have introduced sorry, about signature workflow assessment. And this is really a free service that we provide to laboratories. Right? It's complimentary. We work with the laboratory, whether they're a customer or not a customer, really. We come on site, we help assess your workflow. We identify bottlenecks, but also we discuss best practices with you, and we work with you towards addressing those bottlenecks. This is a free service. You don't have to be, we don't get paid for this. This is just our way of really sharing some of the knowledge that we have had, through being in the industry for 30 years, to the market. So please feel free to take advantage of this. If you want to apply to it, you can go to novopath.com, /workflow to apply for it. Without further ado, I think that concludes the formal section of the webinar. Thank you, John David, for really a very exciting conversation. As I learned a lot, when things hopefully in a good note, positive note around some of the reimbursement, increase coming for pathology laboratories and some of the technology, adoption and trends that we're seeing. So I'm going to open this up for Q&A. Let's see. So I've got some questions here. I'm going to ask this out loud. So, the question is around digital pathology, and uh, the question is around how digital pathology has been said to increase efficiency. And there were several early adopters of digital pathology, such as Kaplan, who have not really seen the individual pathology efficiency. Can we talk and speak on that? John David, could you take on that, and then I can add to.
Yeah, I would say this, that the real efficiency is not going to come from digital pathology. It's because it's an extra step. It costs money. And you could argue whether or not there's any efficiencies that result from strictly just digitizing your slides and sending images over to the pathologist computers to read. So, and I have questions about that myself. But the real efficiencies are going to come from the application of artificial intelligence. So if you can run, and artificial intelligence requires a digitized image. So you can't get to artificial intelligence unless you have digital pathology first. So my opinion is that digital pathology in and of itself doesn't provide many efficiencies. It's nice, and I'm sure pathologists who can read slides at home on their computer monitors are very appreciate it very much. But the real efficiencies are going to come from artificial intelligence. If you can run every digitized image overnight through an artificial intelligence program or several artificial intelligence programs, and then you can have each image hotspots on each image to direct the pathologist's attention to. If that can increase the ability for a pathologist to read slides by 20, 30, 40, 50%. I mean, I hear all different kinds of numbers. Then that's where the efficiency is going to come, not strictly from digital pathology by itself, but it'll ultimately come from the application of the AI programs that will help pathologists read more cases per day.
I know. We have another question around, we talked about the clinical clinical lab fee schedule, potential cuts. One of the attendees really wants to understand are we talking about this potentially impacting pathology rates, or is this just for clinical labs?
Okay, sure. So the PAMA schedule, the PAMA regulations affect only the clinical lab fee schedule. They do not affect pathology and the Medicare physician fee schedule. So it's two separate fee schedules, and the cuts of up to 15% for, I think it's 792 tests. That strictly applies to clinical lab tests. It does not apply to reimbursement paid through the physician fee schedule, which is the fee schedule that relates to pathology professional fees and pathology technical fees. So it's two separate fee schedules. The bad news is more on the clinical lab fee schedule, and that bad news does not affect the physician fee schedule. On the physician fee schedule, there's actually positive news because of the inflation updates that are written into the One Big Beautiful Bill Act.
Fair enough. There's another question here around the influx of private equity in the regional lab space. Seems to be that there's been an increase in the influx of consolidation in the space. Could you talk more about it? Any insight on it?
Yeah, my insight, and you just have to take this as one person's view, one person's opinion. My insight or thoughts on that would be that the private equity investors are more often than not mostly interested in those clinical labs and anatomic pathology labs with very esoteric, um, exciting tests, not routine clinical labs or routine anatomic pathology labs, but the private equity labs prefer to invest in labs with genetic tests or molecular diagnostics, although that's mostly routine by now, and next-gen sequencing, and the sort of things that are more sexy and more have more glitz to them. And so that's one observation, is that they're more interested in uh, the more glitzy next-gen sequencing, genetic testing types of labs. And then secondly, there are one or two smaller private equity-backed pathology labs out there. There's one in the Chicago area, one in California, but there's nothing like, we haven't seen yet, and maybe this is just a matter of time before we see another AmeriPath or another Aurora Diagnostics. I've heard some people talking about the desire to start a large private equity-backed acquisition vehicle, similar to AmeriPath or Aurora Diagnostics, but that's not out there right now. So I would say private equity, there's a little bit taking place in terms of routine clinical and anatomic pathology labs, but the greater interest is in the more sexy, glitzy, next-gen sequencing or proprietary testing, more sort of single-focus type laboratories. And to be honest with you, a lot of times they can get their head handed to them, because more often than not, those types of labs are losing money, losing a lot of money.
Yeah.
So anyway, that's my 2 cents.
Fair enough. One more question, and this is the last question here, which is, there's been, on the same thread of esoteric testing. I think in the last month or so, it was clear that the FDA did not appeal the court order for the LDT, and obviously LDTs have been in the news in the last year. Could you share more about that, the fact that the FDA didn't appeal, and what this actually means for laboratories?
Yeah, okay, absolutely. So there's another hugely positive piece of news for the lab and anatomic pathology business. So a month or two ago, a court in Texas sided with ACLA and and others in their lawsuit, which said that the FDA had overstepped its bounds and did not have the authority to regulate laboratory developed tests. So that law or that regulation has been struck down. It no longer exists. You don't have to worry about it. And it's very unlikely that it will be reintroduced anytime soon, especially with the current administration. There are so many other issues to deal with. So LDT regulation, which was law, is no longer law. It was struck down by the Texas court. It was the judge's decision, the Texas court's decision, has not been appealed by the FDA. The 60-day waiting period to file an appeal has come and passed. So And I think the LDT regulation was a much bigger headache, much more costly, much more detrimental than many labs realized. And the good news is that it's been struck down, and you don't have to worry about it anymore. No appeal has been filed, and it's unlikely to be reintroduced. LDT
Yeah.
regulation is unlikely to be reintroduced anytime soon, anytime in the next few years, I would think.
Well, it's great that we're gonna be we're ending the webinar on the positive news. I know the LDT regulation was definitely one that gave me and a lot of lab leaders that I spoke to really a lot of concern for the industry. So it's great to hear that we can move forward and not have to worry about that, at least for probably for the next 4 years throughout this administration, because I don't get a sense that this administration is going to be pursuing something like that. Anyway, John David, thank you so much for your time. We really appreciate you joining this conversation and for all your insights. I hope I can speak for myself, but I do think I speak for all the attendees. We've learned a lot, and this was a very insightful conversation, and appreciate you making this happen. And thank you to
Thank,
everyone that attended.
thank you, Promise. Thank you very much.
All right, that concludes the webinar. Thank you, everybody.